Let's see. We are now going to talk about all the meds that might help the GI dysfunction. And a lot of them are anti-ulcer meds, just varying degrees. And of course, our antibiotics, we'll talk about those, and some anti-inflammatories that specifically may help or how they help. They're basically anti-inflammatories we already know about, but basically help the GI tract. So for drug therapy for ulcers, and we'll probably start there. Basically, what we want to do 4 basic things. We want to alleviate their symptoms because, face it, it hurts. It's burning or sharp pain. Second thing is we want to promote healing so that they won't have the pain. Third, we want to prevent complications, which usually for an ulcer is going to be either a hemorrhage or because of a perforation, a hemorrhage, and obstruction. It's going to obstruct the food, chyme, pepsin, exudate moving down the intestinal tract. And then the fourth is to prevent reoccurrence. So again, we're going to alleviate the symptoms, promote healing, prevent complications, and hopefully prevent the reoccurrence because through medical regime and diet. Very important because it's the gut. Okay, classes of anti-ulcer drugs, and we're going to talk all about these separately also, but we have obviously our antibiotics. We all know what that is. We've got our anti-secretory drugs, which are either our histamine 2 receptor antagonists. And what does that do? These drugs came first to block acid. And then we've got our proton pump inhibitors. What the PPIs do, or proton pump inhibitors, they block the last enzyme in the system that actively transports acid from the gastric parietal cells into the GI lumen. So those are amongst some of our strongest drugs against gastric acid. And then we have our muscarinic antagonists also. We've got our mucosal protectants, which are basically going to promote mucus, and we'll see why. Why do we need mucus in the gut? We're going to talk about that as one of the defensive mechanisms in just a minute. And then we've got our anti-secretory agents that enhance mucosal defenses. They kind of go together with the mucosal protectants. And then we've got our antacids, which basically just neutralizes the acid. So they're about our weakest one. The acid's already there, so it can already be causing damage, but it will neutralize the acid for mild attacks. It's not for, or it's basically for heartburn, where our PPIs, which are strong ones, are proton pump inhibitors, because they're acting on the enzymatic level at the cellular level, so that the enzyme is not transported. It doesn't transport the acid from the gastric area out the lumen. So from this classification, we can see that drugs, the drugs for ulcers anyway, act in 3 basic ways to promote ulcer healing. Specifically, they can eradicate H. pylori, which is usually the bacteria in the gut, Helicobacter pylori. That's why we call it H. pylori, and I'll be talking about that more later. Antibiotics do that. The second one is we want to reduce gastric acidity. That's our anti-secretory agents and antacids. And third, we want to enhance mucosal defensive through medications such as sucralfate and misoprostol, and we're going to talk about those in just a minute. So if you don't get all this, don't worry about it. So again, from this classification, 3 basic ways to promote ulcer healing is to eradicate H. pylori, to reduce the gastric acidity, and the third one is to enhance mucosal defenses. So here we are. This is the bacteria. In 1997, National Institute of Health Consensus Development Conference recommended that all patients with gastric or duodenal ulcers and documented H. pylori infection be treated with antibiotics. Before this, they were never treating ulcers with antibiotics. Anybody newly diagnosed with peptic ulcer disease or PUD, recurrent peptic ulcer disease, and peptic ulcer disease in which NSAIDs was a contributing factor, because we know nonsteroidal anti-inflammatory drugs will erode the gastric area and it can cause ulcers. To hasten healing An anti-secretory agent should be given with the antibiotics. But before this, they were not treating with antibiotics. And like I said, after this Health Consensus Development Conference got together, because they were looking at millions of people that we were not helping. So let's see, what do I have on this? Most ulcers are caused by H. pylori, or that's a theory. They don't know it for sure, but they think it. It's a gram-negative bacteria. This bacteria promotes healing and greatly reduces the chance of reoccurrence. I'm sorry, the bacteria does not cause that. Eradication, getting rid of the bacteria, obviously. Eradication or getting rid of this bacteria, that's H. pylori, promotes healing and greatly reduces the chance of reoccurrence. Peptic ulcers develop when there is an imbalance between mucosal defensive factors and aggressive factors. So I'm going to say that again. Peptic ulcers develop when there is an imbalance between mucosal defensive factors, the defending factors in the body, and aggressive factors. And I'm going to talk about that in just a minute. It's talked about, yes, in the patho part of the lecture. Major defensive factor is going to be mucus and bicarb. And major aggressive factors are H. pylori, NSAIDs, gastric acid, and pepsin. Oh, I thought we'd talk about it here. I guess it was the other lecture. Okay. So hopefully you listened to that one first. I'm going to say that again. Peptic ulcers develop when there is an imbalance between mucosal defensive factors and aggressive factors. Talked about this in the patho part of the lecture. It's in the very beginning part, so make sure you listen to that prior to this one. Major defensive factors are mucus and bicarb. The major aggressive factors that are going to tear that down are H. pylori, NSAIDs, gastric acid, and pepsin. All ulcers can be complicated by hemorrhage and or perforation or obstruction, which I think I already said. H. pylori colonizes the stomach and duodenum. So what that means, it takes up residence there. It's housed there. And it takes up residence in space between the epithelial cells and the mucus barrier. It's not supposed to be there, but it resides between the epithelial cells and the mucus barrier that protects these cells. So this bacteria escapes destruction by pepsin and acid, and that's why it just proliferates. 10% of Americans have a pelvic, not pelvic, you can tell them in OB-NERS, peptic ulcer disease. 4 million get ulcers each year, and that's out of your textbook. So, okay, now that we've established what H. pylori is, where it resides in that epithelial layer in between the cells, so that it's not really protected, or it is protected by the mucus blanket, and the acid and the pepsin can't get to it. So antibiotics used for the eradication or getting rid of H. pylori: amoxil, highly sensitive, and it's bactericidal; bismuth, Pepto-Bismol, Biaxin, Flagyl, but they're now saying for metronidazole, 40% of the strains are now resistant. Tetracycline, and this is what's suggested from that committee, that conference. They say administer triple therapies for 10 to 14 days. So you're never just going to give one of these. The treatment regimens are Prilosec, amoxicillin, clarithromycin for 10 days, bismuth, Flagyl, and tetracycline for 14 days, and lansoprazole, I don't think I have that one up there, Flagyl and tetracycline, amoxicillin and clarithromycin, which has been approved for either 10 days or 14 days. So you can see it's not all of these, but it's one of the group of 3 is what they suggest now. I also want to let you know, bismuth, it can cause a harmless black coloration of the tongue and the stool. So we need to let people know that over time. Patients should be forewarned. They may think it's gastric bleeding, especially they've already got problems now with their belly, when it's just caused by this medication. Long-term use of Pepto-Bismol, and of course you can buy it over the counter, but long-term use can cause neurologic injury. So once again, Tylenol we can buy, we know it can make your liver fail. Now Pepto-Bismol can cause brain damage. If Flagyl is sensitive, it's highly, highly effective, and that's why they used it for years, and now it's becoming resistant. In 2007, the American Gastroenterology issued updated guidelines for managing H. pylori. To minimize emergence of resistance, the guidelines recommend using at least 2 antibiotics, but again, preferably 3, which I just put up here. So don't go with 2, go with 3. That's the new finding. And we also know, just hopefully you're carrying a lot of this information in your head, you're not forgetting it, but we know that tetracycline cannot be given to young children or pregnant women because it will stain developing teeth of the baby and the child. Also use, and with all of these, an anti-secretory agent, a PPI, or histamine 2 receptor antagonist. All these are keeping the acid at a lower rate. Okay, that's enough about antibiotics. Okay, histamine 2 receptor antagonists. Why do we need hydrochloric acid anyway? Because it seems like it's bad, when you look at the holes in people's guts. Well, it aids in proper digestion of food. It's the primary substance secreted in the stomach that maintains the environment of the stomach. It helps us so that if we do ingest pathogens, it can get rid of it. And it has a pH of 1.1 to 4, so we know it's acidic. We know that's very acidic. It's the lower end of that pH range. And it serves as one of the body's defenses against microbial infection via the GI tract. Several substances stimulate hydrochloric acid secretion by the parietal cells, and those are the cells in the gut, such as food, caffeine, chocolate. You can kind of see it's the enes, and alcohol too. In moderation, any of these is usually not a problem. However, excessive consumption of large fatty meals or alcohol, as well as emotional stress, they don't know why, but emotional stress can definitely result in hyperproduction of hydrochloric acid from those parietal cells in the belly. And what that does is it leads to hypersecretory, not secrets, but that it's secreting very highly disorders, and we end up with peptic ulcer disease. Okay, let's see. So H2 receptors, what are those? They are activation of H2 receptors, which are located on the parietal cells of the stomach, promotes secretion of gastric acid. By blocking the H2 receptors, the antagonists reduce both the volume of the gastric juice and its hydrogen ion concentration. It does not reduce the symptoms of allergy, just gastric acid. Okay, so first choice drugs to treat gastric and duodenal ulcers are our histamine 2 receptor antagonists, and we now know why. The H2 receptors are located on the parietal cells in the stomach, and it promotes the secretion of gastric acid. And there it is. Promotes healing by suppressing secretion of gastric acid. We have Tagamet, Pepcid, Axid, Zantac. They put everybody in the hospital on Pepcid. We know that. Tagamet, at one time, cimetidine, was one of the most prescribed drugs in America. You can see you can use it all different ways. Zantac is now, they like Zantac a little bit better now. They say it's stronger than cimetidine, and it produces fewer side effects than Tagamet. All of these are over the counter now, and not much difference among them. Let's see. That's about it. Okay. All right. I will go on with the second part of this lecture with the next video. See you in a little bit.